Welcome to the Advanced Diagnostics sleep lecture. So with this lecture, we'll be going over just the respiratory sleep disorders. We won't be going over like the insomnias or anything else like that. It's going to be important to sort of understand the area of sleep, especially if you do want to work in diagnostics, especially sleep diagnostics. There's even a special credential for sleep diagnostics that you can get through the NBRC. It's the Sleep Diagnostics Specialist credential that you can take as well. And I believe at the time of this recording, you can also, as a respiratory therapist, take the RSPGT, the Registered Polysomnography Technician credential as well. So if you plan on working in sleep medicine, those are some credentials you should check out. And it's a pretty interesting field overall. You get to see a lot of different things. There's a lot more highlights of sleep disorders now than there ever was before. And I think more and more people are becoming aware of it, especially general practitioners as well. So it's something to look into. But also, let's say you work in the hospital. Let's say you want to work in acute care and you don't plan on working in a sleep lab. Well, this still can take effect of you. In fact, there was a study that came out that looked at REM sleep in patients in critical care that were on ventilation, and they were looking at how much those people go into REM sleep to look at ICU delirium, and they were trying to look at different things that can contribute to ICU delirium. And sure enough, there was a very poor showing of REM sleep in ICU individuals. And so it's an interesting way to sort of see how diagnostics is creeping in a lot of different ways into critical care medicine as well. So even, like I said, if you plan on never working in a sleep lab ever, and don't ever say ever, because that's usually, a curse on yourself. That's probably what's going to happen. But it still will come in pretty handy understanding sleep disorders, especially when you start looking at patients. I remember not too long ago, I had a patient in the hospital, and this was right before I had retired from the bedside there, and they were a sleep apnea individual, and they'd been in the hospital for about 5 days. They were having headaches, they were sleepy, they were, not doing well overall, and they were having blood sugar issues and pulmonary hypertension issues. And I asked the patient if they'd been wearing their CPAP while they're in the hospital, and they said no, they hadn't worn anything like that. And obviously they weren't already on CPAP in the hospital or anything like that, just for nocturnal use. And so I sent a message to the physician and asked what their thoughts were on adding that to their current hospital regimen. And they agreed, and sure enough, the next day that I was taking care of that patient, 180 agreed, right? This was a big turnaround for that patient. They were active, alert, they're interacting, right? They had a lot better health status that next day. And so you could really make a big difference understanding different sleep disorders, or especially if someone already has a chronic pulmonary disease that causes their oxygen levels to dip to begin with. You had a sleep disorder on top of that. You're asking for someone that's more moody. You're asking for someone that has more health issues. You're asking for someone that's not going to have as good of a quality of life if they don't have good quality sleep. So hopefully I've sold you that this is an important subject. All right, so let's get to it. When we're looking at sleep disorders, according to the National Sleep, this is from your book, approximately 40 million Americans suffer from some type of sleep disorder. That's huge, right? That's a big chunk that's out there, and so it's pretty impactful to the American society. This is not something that's very minimal. This is something that's impacting the nation altogether. Now, I'm not going to have you guys remember that number, but as it might change from year to year or 5 years to 5 years. But I want you to sort of see this is kind of a big issue, and it should be something that is in the forefront of being addressed out there. And I think more and more people are getting better. The National Heart, Lung, Blood Institute estimates that those with sleep disorders, nearly 18 million, have some form of sleep apnea. So of sleep disorders, nearly 18 million have some form of sleep apnea. That's that's respiratory, that's them forgetting to breathe or not being able to breathe at night. That's a pretty big issue, especially for all your organ systems, including your brain and your heart, right? Pretty big issue also when you talk about how people interact daily, right? When we talk about how they interact with each other and how they go about their day, if they have excessive daytime sleepiness versus if they're awake and rested for the day, big difference in their moods, so on and so forth. So there are more than 70 diagnosed sleep disorders out there. We'll not go over all 70 of those. That is for a different course. And in fact, most respiratory bachelor's programs have a sleep course in them. So if you're further interested in this and you are looking more for sleep or more detailed stuff than sleep, including all the parasomnias, insomnia, so on and so forth, that's a great place to learn more about those as well. So this is pretty big. 1 in 6 Americans are afflicted with sleep disordered breathing, right? North Americans, right? So the cool thing about this is in the hospital, you might be the one that recognizes the symptoms that's going on in these patients, like what I was saying earlier with that case that I had right before I hung up the stethoscope there. So it's something that you could play that key role in sort of changing the course of that patient and bringing up to attention with the care team, hey, what are the thoughts on, that this could be a part of a sleep apnea, right? So this is something that you can definitely be impactful for. All right, so when we're looking at this, RSRTs, oh, I sort of previewed myself here, and sleep technologists, you can also be a part of a polysomnography study. So a polysomnogram is the formal sleep study. That's where we put all these different electrodes and wires all over the patient. We have at least 17 different leads. We'll put EKGs, we'll put leads over the eyes, we'll put airflow leads, we'll put leads on the legs, leads on the chest, leads all over the brain. So we'll do an EEG with it, right? We'll put all these leads all over the patient, and then we'll try to have them sleep with all this on and having people watch them, right? But you can actually be a part of this, and it's pretty interesting. If you ever get the chance to do a clinical or to do a small rotation in sleep study, I would encourage it. Even, like I said, you plan on never working there, it's great to expose yourself to that side of respiratory therapy or to that side of medicine altogether, because what diagnostics have going for them is that they are really good at life changers, right? And it's not that people in acute care don't do life changers, but you got to understand that these fine-tuned things that we do in diagnostics can make the difference, a big difference over the course of the life, and not just stabilizing, right? So I'm not downing acute care or diagnostics. I'm just saying diagnostics does play a very rewarding role if you do choose to go towards diagnostics. We provide diagnostic and therapeutic expertise when it comes to these sleep disorders. So not only are we there for the sleep study and help with diagnostic, but we also help with interfaces or options as well for these patients. I remember when I was a student, they used to have things called CPAP Saturdays, and we would go, and it was for professional hours, and it was for people that had sleep disorders, and they would have someone speak about CPAP masks, or someone speak about sleep disorders in one way or another, or they would come and have different companies show their masks and do demonstrations with different types of equipment and all that stuff, and how to clean your CPAPs and all that stuff. It was very rewarding because then you get to sort of see not only are they in the diagnostic realm, but they're also performing therapeutics too. They're also trying to titrate, help these patients troubleshoot and all that. It's pretty interesting and dynamic stuff, and you actually have more time to discuss and talk and enjoy that interaction with your patients too. Like I said, you can perform sleep studies non-invasively and do non-invasive titration in all 50 states as of recording this lecture. And it's pretty cool. We even had in the sleep lab that was at our hospital, the CPAPs were actually remote. So they could change the CPAP setting from the control room of what the patient was doing. So the patient would be sleeping, and let's say they're on a CPAP of 5 and they're still showing obstruction, then we could increase the CPAP to 7, right? And we could do it remote control. We wouldn't have to go into the room and do it. It was a pretty neat thing. And so there's a lot of titration that we can be a part of as well. There is a board for polysomnography technologists. and that you can get the, like I said, the RSPGT credential as a respiratory therapist, or as a respiratory therapist. You can also and there's sleep technologists out there. Now, the big thing I will tell you about sleep technologists out there is they're trained heavily with EEGs, reading the brain waves like REM sleep, the K waves, the spindle, so on and so forth. That's not something we have a lot of detailed training on in our program. However, I will say that, like I said, with most bachelor's and RT programs will offer a sleep track where you can learn better on how to read those EEGs. So you can take the RSPGT, and I like that option of the RTs taking the RSPGT. Just remember, if you take that credential, you do have to keep up your credits separately that will apply separately to that board, to the ABSM board, right? And if you are a respiratory therapist, which hopefully all of you will be, right? You have the option of also taking the SDS, the Sleep Diagnostics Specialist credential. The advantage of you as a respiratory therapist doing the SDS credential versus the RSPGT is the SDS is through the NBRC, right? And so through the NBRC, that means you only have to submit all of your continuing educations to one place. Your RRT continuing education, your RPFT, your SDS, all these credential CEUs that you need all go to one place. So it sort of keeps it all in one tidy place compared to making sure you got your NBRC credentials when your credentials need to be renewed, as well as your ABSM credentials for your RSPGT. Now, it's not too hard to get either way. So ultimately, my recommendation to you is to look at where you want to work or which one appeals to you more. But definitely look with the employer or the direction that you want to go in sleep medicine, and sort of see if the RSPGT might be more advantageous to you or if they'll take the SDS, right? So that's something for you to sort of tease out and make sure that's right for the market you're trying to go into. That was my best advice, right? I don't work for the NBRC. They don't pay me, unfortunately. But there you go. All right, so let's go into the actual sleep stuff. Although ideally providing physical and mental restoration, sleep might be a frustrating experience with sleep disordered breathing, right? Because it can actually make pre-existing conditions worse, right? And it can actually make it into life-threatening scenarios. So if you already have chronic hypoxemia because you have severe emphysema, do you think, and as a normal, healthy individual, if you were to go to sleep right now, your oxygen levels would drop a little bit. I think everyone's oxygen levels do drop a little bit. But remember, our oxygen levels drop a little bit because our metabolism slows. We don't need as much oxygen to supply our tissues, right? So it doesn't mean we go hypoxic and go into a metabolic acidosis every time we go into sleep. It means that when we go to sleep, our body doesn't require as much oxygen and we're not breathing as deep, so therefore we drop a little bit, and it's okay, right? It's not something that's life-threatening. Now you add someone with chronic hypoxemia to the issue, they go to sleep, now their body gets even more hypoxemia on an exponential level, and it can actually cause cardiogenic, neurologic, and multi-organ dysfunction ultimately on these individuals. And in fact, if they reach a level of hypoxemia, their brain actually wakes them up from a deeper sleep. So these individuals may never get a good REM sleep. They may never go into a deep sleep and actually get that restoration they need. And that can actually lead to behavior issues, of course, right? Just like little kids, if they don't get their naps in, like they have those behavior issues, adults have the same thing, right? Have you ever met someone that has emphysema or COPD that was on the grumpier side of things, right? This could be something that's an issue, right? How much oxygen their body's requiring when they sleep might be higher than what we're giving them. And that might be affecting their sleep for sure, and their behaviors for sure. It's an active process. People think of sleep as a sort of a powering down, And that I could understand where someone would see that. However, your brain and your body have an active process going on. So it just sort of depends what type of activity you're talking about. Compared to the daily activity, of course, sleep is sort of a power down in comparison, but you still have activity going on in your brain, right, throughout the night. Your brain waves don't go blank. Thank goodness. You don't want that to happen. That would not be a good thing, right? You have brain waves while you sleep. So sleep is an active process, right? So if I give you a true or false question, sleep is an active process, right? That's true. It is an active process. There's continuous brain stimulation going on throughout the whole night, right? We don't go with blank brain waves. That would be a very bad thing. There's two primary states of sleep currently. There's REM and non-REM sleep, so non-rapid eye movement and rapid eye movement. So how do we know someone's in REM sleep? Well, we can look at the EEG waves, but however, as you'll see soon, I'll give examples of the EEG waves. That's not always clear, so we also have to have something that's sort of looking at eye movement as well. So if we see active brain waves as well as the eye movement, then we know that they're in that deep REM sleep. So REM sleep, or rapid eye movement sleep, you'll see rapid fluttering or rolling of the eyes, and the eyes aren't necessarily open here, they're closed. And then you'll see that their muscle tone decreases during each non-REM phase and even in REM phase. And REM phase, the muscle tone will be at its lowest. So let me ask you this. If muscle tone decreases, the deeper sleep goes. Which stage of sleep, REM or non-REM, do you think would have the most sleep-related breathing disorders, especially with obstructive sleeping disorders, right? That was going to be your REM sleep, because your body is not trying not to act out the dreams, right? You don't want your body to be acting out the dreams, right? That's where people have those night walking and all that other stuff that goes on, sleepwalking, all that big stuff that goes on there. So when we're looking at REM sleep, that's where a lot of times in stage 1 and stage 2 of non-REM sleep, your body doesn't necessarily need that CPAP in a lot of cases. Some people might, but a lot of cases their body hasn't relaxed, or their airways haven't relaxed to the point where they would collapse yet compared to a REM sleep. So that's why some people, you'll see something on their CPAP machine called a ramp. And you can actually set the ramp, where I start the CPAP machine at a CPAP of 3, right? And I'm just giving you blank examples here. I'm starting a CPAP of 3, and as this patient goes further into sleep, and I can set it for 90 minutes to slowly ramp up over the course of 90 minutes to a CPAP of 8, right? That would be their prescribed CPAP. Because I know unless they have narcolepsy or something like that going on, they're not going to hit REM sleep within the first 10 minutes. And in fact, a lot of people have trouble falling asleep with their CPAP on, right? So if I give you a very low level, like a CPAP of 3 as an example, and I tell the machine wait 90 minutes, and over the course of 90 minutes, you're going to slowly turn it up. So that way the patient A can fall asleep in the first place more comfortably, but B, when they get to that first REM sleep, which usually isn't until about 60 to 90 minutes or so, then they have the prescribed amount they need for when they need it the most. And I hope that makes sense. So the ramp feature, I think, is great things. There's other things like C-Flex that allows for a lot easier respiratory motion with it on. So there's more and more advancements, it's very nice to have those nowadays. All right, so I will talk a little bit about kids, especially neonates, when we start looking at some of this stuff, because you're going to start to see apnea prematurity, and we'll talk about that in perinatology as well. Babies, these REM sleeps, infants up to 6 months of age, their brainwave patterns do not yet conform to the standard adult classification. So active, quiet, and intermediate sleep do illustrate ambiguity in the young individual. So if you plan on working in a children's sleep lab or looking at EEGs of kids, this is going to be different. So that's what I'm just saying you right now. Those EEG children's sleep disorders, they're going to look a little bit different than your adults. So if you're used to the adult sleep test and you go see a kid's one, there could be some minute differences there. REM and non-REM stages will cycle back and forth between 60 and 90 minutes, just like what I was saying there. Usually you'll get about 4 to 5 cycles for adults during a normal sleeping period. That would be great. An 8-hour sleeping period. I don't know who put that together, but I don't know. Maybe they mean continuous instead of like intermittent sleeping. Sleep occupying 1/3 of our life, hopefully. The quality and quantity of sleep have long-range health and quality of life implications. It is very vital. The more and more we're learning about neuroscience medicine, as well as sleep disordered breathing, as the advancements go, how important sleep is. It's going to become stronger and stronger out there, and we're getting better information year after year on neuroscience and sleep and how sleep relates to so many other health conditions and behavior conditions, especially with kids too, as we look at this. So let's start with the first of the two primary stages, so non-REM sleep. So we'll do non-REM and then we'll go into REM later. So non-REM sleep is what usually you'll start off in. So the first couple minutes up to about that first 60 to 90 minutes, you'll be in that non-REM sort of stage. Within non-REM, there are subcategories, and we'll get to those. The big thing that we'll be looking at with the polysomnography test is we'll do an EEG, an electroencephalogram. So this is looking at the brain activity, and then we can sort of see the resting restorative state when we're in non-REM sleep. So that's a resting restorative state when we're in non-REM sleep. There are 3 stages of non-REM sleep. The way that they can tell the stage is by looking at the EEG tracing. Right? So just like you can tell if someone's in pressure control or volume control by looking at waveforms on a ventilator, and hopefully you can, but just like you can tell if someone has air resistance or low compliance on ventilator waveforms, same thing here. We can look at the amplitude, right, how big the wave height is, or the frequency of the wave height on the EEG tracing, and sort of see which stage of non-REM sleep they're in. So stages are broken down to non-REM 1, non-REM 2, and non-REM 3. So N1, N2, and 3. The N stands for non-REM, which each progressive stage of non-REM, the state is deeper and deeper. So N1 is light, N2 is deeper, and 3 is deepest as far as the non-REM stage goes. Right? The EEG, it's we're looking at the brain waves here, and we're using a 10 to 20 system when we're doing this because we're looking at the relation to the landmarks of the human head when we're doing this. We're looking at the brainwave activity to look at the different stages and what was happening to their body during the different stages. And what will happen too with a lot of these formal sleep studies is we'll record it during the night, and then they'll have someone that sort of scores it the next day, and then a sleep doctor will look it over. It's pretty interesting stuff. EEG arousals is something that we'll look for if it's disrupted and we see a change in their EEG tracings for at least 3 seconds. We know that that's an EEG arousal. Something happened that caused that arousal. Situations that can cause these arousals can be loud noise, right? Room temperature, for sure. A bad dream or nightmare, body positioning in the bed, and then finally an apnea episode. And that's the one that we're going to be looking at for sleep breathing disorders, is the apnea episode part. Patients usually will be aware that they have will not be aware that they have sleep apnea, but they might comment that they waken from sleep with a gasp, a snort, or a loud snore, right? They sort of wake themselves up. And so do you ever wake yourself up when you sleep? And you'll see, I think in here I go over the stop bang, the Epworth sleepiness scale, so on and so forth. And that's one of the sort of questions that they look at is, do you ever wake yourself up? Or we'll ask their significant other, do they ever wake themselves up? And a lot of times they'll remember over the person themselves. So non-REM, children and adults normally begin with N1. You will have slow rolling eye movements in this stage. So when we're looking at that part of the tracing, it's slow. It's not rapid eye movement. It's slow rolling eye movement, right? Remember, REM is rapid. Non-REM is slow. Notice that I'm making a point there. The brain waves will have very low amplitude and mixed frequencies when you're looking at it. You should only spend about 10% or so of your sleep period in this N1 stage, so it shouldn't be primarily, and that's the trouble here, because it's such a light stage of sleep, your muscles are the least relaxed here, and that's when you're going to have probably the highest oxygen levels. So if you do have something like emphysema or a bad pneumonia going on, do you think your body is going to allow you to go into the deeper stages where your oxygen level drops too low that the brain is getting reduced oxygen delivery, right? It's not. And so that's why in some of these patients with chronic respiratory diseases or even acute respiratory diseases, they have an issue where they're not getting the sleep they need, and it really affects their mentation and mood and behavior for sure. Right? Within 2 to 10 minutes of sleep, usually you should then progress from N1 into N2. So it shouldn't spend too long in N1. N1 is more like you're daydreaming, right? You're just sort of drifting a little bit. But if someone were to bump you, you'd be like, oh, no, I wasn't sleeping, right? I was just sort of drifting, right? And N2, you're going to start to see some changes in what's called K complexes. And sleep spindles is what they're called on the EEG waveforms. So we're going to start to see some changes in the EEG as the brain starts going into a deeper stage of sleep. In adults, you should spend about half of your sleep cycle in N2 overall. And this is more common. The older you get, the more you'll spend in N2. And then when we get to N3, I'll talk about that one. That one has a lot to do with hormones. And as we get older, less hormones. And so that can really affect N3 in our sleep habits as well. So N3 is considered the deepest stage of sleep. I'll repeat that again. N3 is considered the deepest stage of sleep. I'll repeat that one more time, and hopefully you'll remember it for, an exam. N3 is considered the deepest stage of sleep and is about a quarter of the sleep period. So hopefully you get some time here in N3. You're going to start to see slow wave sleep. In other words, the brain waves are going to start to slow down a little bit, right? So they're fast. Then we have in N1. Then in 2, we're going to start to see those spindles and bundles start to appear, and then we're going to see them slow down in N3. We're going to see very high amplitude waves, so peak to valleys, right? It's hypothesized to be the physically restorative side of sleep. So if you went and ran a marathon, right, then this would be your physically restorative side of sleep, right? This would be that when they talk about how good sleep hygiene, one of the ways to get good sleep hygiene or to help with good sleep hygiene is actually physical activity. Now, physical activity, as far as evidence-based goes, isn't there for as much evidence-based for weight loss. It's evidence-based for physical health as well as for mental health, and then it also helps with sleep as well, unless you're doing it right before bedtime. That's a whole separate thing. But you got to let your body cool down before bedtime for sure, as far as your adrenaline during a workout, or I guess it depends how intense your workout is. If you do a slow yoga workout, that might be a little bit different there. So this is going to be your most physically restorative sleep is N3. Your sensitivity to external stimuli, someone closing a door, someone making a loud noise, going to be pretty diminished. That's also why hospital patients in the hospital, classically, I always used to joke with some of my patients that you come to the hospital to get sleep deprived and you go home to get healthy, right? And so it's one of those things where the more and more we're focusing on patient experience in the hospital. Can be a good or a bad thing, depends how you look at it. I will say a bonus of that is now people are more cognizant of patients getting sleep and how sleep can actually help their physical recovery. And this is going to be one of the big things, right? Because especially when we co-bedded patients and stuff like that, or put people in rooms together, right? Co-roomed patients and stuff, we were having that issue with sleep, and then people waking everybody up at every 2 to 4 hours, right? And so they're going to have a hard time going into these deep physically restorative states that's going to ultimately help their recovery. So if they are able to get to N3, their stimulation to outside stuff is going to be diminished. These people are going to be a lot more difficult to wake up because their brain is finally in that slow wave sleep. The amount of time you usually spend in this stage decreases with age. Boo! Right? You should all be booing right now. Dropping as much by as much as 50% after adolescence there. And that's going to be a big thing, right? And that's why kids, especially if you look at behavior issues in teenagers, and they're starting to catch on with schools now, where schools for kids, high schools and junior highs, are actually starting to do later start times, so that way kids can get even more sleep under them, and that actually helps reduce behavioral issues, which is finally the evidence is catching up to the general population there, and it shows, and it shows that they do better in school overall when they can actually have that later start time or improve their sleep overall. Essential growth hormones are released during this stage, which means if a child that's in this stage does not get enough sleep, then that can have a health detriment to them as well, right? Especially during the first half of the night. So that means they really need to get that going. They need to have that in order for them to have that proper growth and development and mental health as well. I believe this is straight from your book. I hope it is. If not, it's here for your reference. These are the different EEG waveforms. For N1 is at the very top there. These people are sort of awake. You can see how rapid and fast and shallow those little spikes are, right? And then when you get to N2, you see the spindles and spikes, right? The bundles. You see how there's some that are bundled and then slow, bundled and slow. Then stage 3. Right, you can see how you sort of have it slow down, right? As you get further, you get to the delta sleep down there. Do you see the delta sleep? From the very top waveform all the way down to the delta sleep, you see how it's slowed down, and then your peak to valley, also known as your amplitude, right? How tall those waveforms are increased, and then at frequency slowed down. You don't see as many waves, right? You see them slow down and get deeper, right? Big mountains, right? And then finally REM. What do you notice about REM? And here's the thing I hopefully you see when you're looking at this. When you're comparing awake and REM, what do you see? What do you see between these two? They look almost identical. Interesting. So let's get into this further. So non-REM, one of the neat things about non-REM is it comes with other things too. Your control of your body temperature and regulation of breathing, pretty straightforward. You maintain that pretty easily. So you may not need a blanket during this stage of sleep, right? Your respiratory rate will slow down during this stage. Your tidal volume slows down, it gets smaller. You'll get a little bit of increase in your CO2, which means more parking spaces are taken up by CO2, and therefore your oxygen levels will drop a little bit. That's okay, right? That's okay because as long as we have a good reserve, right? Remember, our oxygen extraction ratio is 25% normally, right? And so we have the 75%. We have the 75% left in our bank to still get good oxygen supply to our muscles. So we're not causing detriment to the body. This is a normal physiological change. So our minute ventilation drops, all right, in non-REM sleep. And that's because we're not awake. We're not as metabolically active as we were when we are awake, and so that's why that's going to change. So we'll have an increase of CO2 very minimally, right? 2 to 4 millimeters of mercury. That's very small. That's a very small drop in the bucket overall. It's like being slightly. It would have very minute changes on mentality, minute changes. If you retained 2 to 4 millimeters of mercury, it's not going to really change your interactions too much, right? It's not a significant hypercarbia. Blood pressure should go down during this stage, which is great. With age, your percentages of time in N3 decreases. That means as you get older, the time you spend in lighter stages increases. Let me hear the boos. Boo, right? Because N1 and N2 are lighter stages of sleep, you have a higher incidence of insomnia here, and understandably reported with age. So in other words, as you get older, if there's an insomnia there, it might amplify itself the older we get, unfortunately. Non-REM occupies about 75% of your sleep period, give or take. We're talking just in general here, and includes your slow wave restorative sleep, as we were talking about. All right, so we talked about non-REM. In that category, within the non-REM category, we had N1, N2, and N3. You should know what happens to your body as you progressively get deeper, which of those is the deepest stage, so on and so forth. During REM sleep, the brain is active. I'll repeat that again. During REM sleep, the brain is active, right? So dreaming almost always occurs during this stage. You have an increased duration of about 25%. REM episodes increase in duration the further through the night you go. So if you're only at a 3-hour sleep period, let's say you have an exam the next day, and somehow you decided instead of studying for 10 minutes a day, I'm just going to cram the night before. All right, guilty? Anybody out there feeling guilty? So let's say you only get 3 hours of sleep before this exam. Well, if you only get 3 hours, you might have just 1 to 2 REM stages. Now, as you go along, let's say you sleep 8 hours, you're going to have maybe 3 to 4 within a time period towards the end of your sleep. So the longer you're asleep, the more frequent the REM cycle will come around. So that's good, right? That's where your brain gets that restoration part from. The EEGs demonstrate a mixed frequency that looks almost the same as N1. So remember that picture that we just read a little bit ago where I sort of drew that line that connected the awake stage to the REM stage? Notice how the brain looked like it was awake, right? We had awake brain waves, and we know that patient wasn't awake, right? They will also have rapid eye movements in the screen. So this one, you'll see that the eye movements will sort of cross, right? You'll see the eye movement sort of cross on the EEG waveform. And don't worry, I'm not going to test you on that, but if you are doing a sleep lab clinical, that's something that you may see. And once you see that cross, and then you see the brainwave activity look like awake activity, then you know that they are in REM sleep. And I think for my sleep lab clinical, when I was doing my bachelor's, I had to wait. I had to be there until someone went into REM sleep, and then I had the option to leave, which of course I picked at that time because I was still working at the hospital while I was getting my bachelor's and all that stuff. So pretty neat to sort of see that. You're going to see the EEG waveform look the same. They'll see a decrease in muscle tone, hopefully muscle activity. At the lowest levels, the EMG, so the muscle activity, and they're going to have one at the chin that looks at muscle tone. It's going to look like the patient sort of has a paralyzed state, which is good because that means that they're not going to be acting out that dream or that nightmare. You're going to see their minute ventilation drop even more than non-REM sleep. This is, of course, meaning that their oxygen levels could drop further. And that's why we might not see people that actually go into REM sleep with acute respiratory diseases or even chronic respiratory diseases, right? Healthy adults and children produce associated episodes of hypoxemia and hypercapnia in this stage. This is the stage that if it's going to happen, it's most likely to happen during REM sleep, where you have a sleep-related breathing disorder. REM, you'll have a loss of skeletal muscle tone like we already talked about, and that includes the pharyngeal muscles. That means that your throat muscles will be very relaxed, which means your airway resistance will increase. And because of Posey's law, you're going to have more turbulent airflow as well. So relaxation of the tongue, all that soft tissue, the pharyngeal muscles, will cause air resistance to increase, make it work harder to breathe. Your heart rate can easily be variable during REM sleep as well, depending on what you're dreaming or nightmaring about. Hopefully you guys aren't nightmaring out there. But so this is sort of where you'll see that loss of muscle tone, that where those people will go into that obstructive apnea situation out there. So heart rate is variable during REM sleep. I would make a list of REM versus non-REM. Heart rate is variable in REM, and cardiac arrhythmias are commonly seen in REM because what's happening with their breathing, what's happening with the heart rate, what's happening with all those other things, right? This is where they're at that deep stage, and so they're more likely to show those arrhythmias while they sleep. The body temperature regulation decreases. This is why you might wake up in the middle of the night and then be like freezing cold, and you're like, how did I not, right? They lose the body temperature regulation in REM sleep. Blood flow to the brain, the cerebral blood flow, and the cerebral temperature increase because of the increased brain activity. So your brain is running a marathon here during this REM sleep, right? All that dreaming and all that stuff, resetting all those hormones. Physiologic effects of REM may be more profound in patients with pre-existing pulmonary or cardiac disease, people that have heart failure, people that have any pulmonary, chronic, or acute pulmonary disease are going to have a lot of issues. If they do go into REM, REM is going to amplify their desaturation. It's going to amplify their cardiac stress. So that's why it's very important if you have patients that are cardiac and or respiratory patients. Sleep can actually put stress on their body, so we got to watch out for that. REM may precipitate increased complications, right? That's what we talked about. Their ventilation, blood pressure, heart rate for these particular patients can cause more stress, and therefore we got to be careful that their body may not allow them to even go into REM too. So REM should take up about a quarter of your sleep time. You're going to see a lot of very active brain activity, dreaming. There should be partial paralysis of the skeletal muscles during REM sleep. That's why it's important to make sure that whatever therapeutic effect we have for them that do have sleep apnea of some sort, that it's highest, or that it's therapeutic during REM sleep as well as non-REM sleep. So what's sleep architecture? So this is the pattern of sleep stages that you'll go in throughout the night. And there's some stuff out there like people's Fitbits and things like that that can sort of give you a rough idea of your sleep architecture. Is it anywhere as accurate as what you'd get during a sleep lab? I would submit to you that as of currently, no. I'm not going to say it's going to replace a sleep lab or a sleep study, but it's pretty interesting. And this is something that like your Fitbit can give you. Not a sponsor, unfortunately. Approximate percentage of sleep time, it'll tell you how much time you spent in the different sleep stages of non-REM as well as in REM. And so we can actually look at a graph and sort of see someone's sleep cycle, how often they went into REM sleep, how much they spent in stage 1, stage 2, stage 3, and REM stage. And it will vary based upon how tired you are. If you ran a marathon, you might spend more non-REM time than REM time. If you had a very mentally taxing day, you might spend more time in REM than non-REM, right? So physical exertion during waking hours and lifestyle choices, especially the types of nutrition or how much caffeine someone consumes, how much alcohol someone consumes, there's so many factors that go into this. If they do business in their bedroom, or if they do their business where they study and write papers and all that stuff, do they do it in their bedroom or do they do it in a separate room, right? Your bedroom should be for sleep, right? It's that environment that should not be for watching TV. It should not be for looking at your Instagram. It's not for that type of thing. That's something that keeps your brain awake. And if you make that room about keeping your brain doing things in your room that keep your brain awake like that, your room no longer becomes associated with deep sleep. Your room becomes associated with things that keep your brain awake. And so that's one of the sleep hygiene things out there, is to make sure your bedroom is for sleep only, right? It's not one of those other things. You're not going to use it to watch TV or to look at your social media or anything like that. That's something that will keep your brain going and ultimately affect your sleep architecture. Histogram is sleep architecture, and it depicts the time spent in each sleep phase. So this is what we're talking about. The sleep architecture looks at the sleep cycles, and the histogram, right, is the actual graph that we get to see from this, right? So this is an example of a, what is it called? Histogram, right? Histogram, right? So this is something, like I said, people's smartwatches and all that stuff can do, and it looks at your wakefulness, your non-REM, and then your REM stage. And you can see on this individual, they had one REM early on here, and then as they got further on into their sleep, it became more often than it did early on. Well, that matches what we were talking about early, where the longer your sleep, the more frequent those REM episodes will happen, right? And you can see this person spent a lot of time in N2 and N3. Good job. Good job, whoever this person was. And normally when you do cycle into REM sleep, when you're done with your REM sleep, you'll cycle back up to stage 1 and then start it all over again. And then, once you're done with the REM stage, then you'll cycle back up to stage 1 and go back down again. So that's sort of that normal pattern. Now you can do it here, like where this patient went from N1, N2 to N3, and then back up to N1. Different things like that happen all the time, but that's that normal step down is what you're looking at here, is in general what you might see. So during normal sleep, we begin with N1, we go to N2, and then reach to N3 as sleep deepens. During REM sleep, the brain is in a state of rest. Even though the EEG is active, the body can still move and respond to stimuli during REM sleep. This is why you might find yourself sort of in a different position than when you went to sleep and not remember it. REM is initiated. The brain becomes more active, right? This is where your EEG changes, and then you're going to see the paralysis of your muscles. So hopefully that you don't act out your dreams and nightmares. Minute ventilation changes. Blood pressure and heart rate can jump up or go down. It becomes pretty variable. It depends what's going on during that stage. In most dreams, and most of the time, if you go into psychology, I know you guys are all interested in that, but if you go into psychology, actually more of your dreams are nightmares than actual good dreams, but that's a whole separate thing. When you go into the sort of psychology of things or how the brain works in that manner, but your breathing, your blood pressure all become variable in this stage, and this is where you might be able to see your breathing disorders like your obstructive breathing happen here. Remember that soft tissue in the pharynx relax, that will stop the cessation of flow, and then obviously their pulse ox will drop as well as their CO2 will subsequently increase. So one of the things they might do in a hospital is they might do a sleep study with just a pulse ox, right? We'll put a pulse ox that sort of records throughout the whole night on a patient, and then we'll collect it in the morning, and we'll send that, and we'll even do that on little babies too, right? And send that to the pulmonologist for them to look at, and they're looking for how badly do they desaturate and how often do they desaturate when they do it. So They can sort of tell we can titrate oxygen use during sleep without doing a formal sleep study. Does that mean that that's going to really help them solve this altogether? Absolutely not. But it's something that we can do in the meantime. If the patient is waiting to be healthy enough to do a formal sleep study or anything like that, but something we can do to sort of look at nocturnal desaturations. Is that a problem with this patient? And this can be done at home too, not just in the hospital. The brain is the most sensitive organ in as far as changes in oxygen. So when the brain looks at P little AO2, it's going to be pretty sensitive, and it's going to see if that PO2 is low. It's going to stop you from going into this deep sleep because it knows that that's when it gets deprived, that's when it's getting choked of its oxygen. So if your brain sees your oxygen level gets too low, it's going to stop you from going into that deep sleep and then wake you up to N1 and 2. Well, is N1 and 2 good for physical and mental restorative sleep? No, right? It is not deep enough to get that good mental and physical restoration. So that's one of the reasons why you're going to see a lot of unique behavioral and physical issues, chronic fatigue, and all that other stuff with these patients that do have this issue. Especially if they have chronic respiratory disease where their level drops at night. It's pretty bad, right? As you regain control in the non-REM state, ventilation is restored, your CO2 gets better, so that's why it'll bring you back up to N1, N2 instead of just sort of waking you up altogether. Right. So when this happens, when we see them sort of go from a deep stage, they get an obstructive episode, it wakes them up back to N1 and 2. This is called an EEG arousal. Right. It occurs times throughout the night. So when we're looking at the EEG arousals, that's something to pay attention to because that's when the brain's oxygen levels felt threatened, right? And so it's trying to wake up the patient. So if they begin to transition to REM sleep, they must be interrupted to resume breathing is ultimately what's going on here, right? And so patients will report they have not had dreams for years. Can you imagine that? This just going on year after year. They'll wake up tired. They'll wake up physically exhausted. They'll also have those sort of morning headaches going on as well. And then the other thing that we'll be looking at is the excessive daytime sleepiness. And so there's something called the Epworth Sleepiness Scale. And that's something that we can use to sort of screen for the potential of a sleep disorder. And one of the sleep disorders could be that respiratory related arousal, right? So sleep studies in patients may document up to 400, that's not a typo, to 600 EEG arousals per night, and they won't go into REM sleep. Isn't that crazy? So these people will be chronically tired, right? They'll be chronically altered in their mental status a little bit, right, as far as their behavioral and emotional status as far as that goes. So when the sleep architecture is disrupted, they're going to have what's known as excessive daytime sleepiness as a result. And that's why we can screen for this, and then we can sort of see, is there an issue with it, with a sleep disorder? So full polysomnography test is the most accurate way to find your sleep architecture. Unfortunately, I don't think as of recording this, your smartwatches and stuff are as accurate as they need to be. So once we get a sleep study on these patients, we can titrate our positive airway pressure devices or whatever we're using on these people to get them to a normal sleep architecture. And that's why you'll see what's called a split night every once in a while, where we'll have a patient do a sleep study. First half of the night is diagnosing them with a sleep disorder, and the second half of the night is putting them on a CPAP and then titrating it for their disorder. So that way you're only in there one night, or the patient's only in there one night, and they get both the diagnosis and the therapeutic evaluation all at once, which is great. The goal should be an L there. The goal in treatment of sleep disordered breathing is to minimize arousals and sleep disruption, and help achieve normal sleep. Notice this is bold and underlined. Have I ever highlighted something like bold and underlined and said this could be good to know, especially in the future? Right, so this is the goal, is to minimize arousals and disruptions and get to a better sleep architecture overall. That sleep architecture is going to be a big goal, getting them back to where they can go into those deep sleeps and get their body back into that recovery. Physical examinations are frequently non-specific and unremarkable for patients with sleep disorder breathing. So they could be like, I'm just tired, depressed, I'm moody, right? That's just life, I'm angry, right? And so it's hard for general practitioners to really sort of tease out that it could be a sleep disorder, right? There's a lot of things. They could be hypertensive, they could have arrhythmias, they could be gaining weight because they're tired, so they're eating more to try to get more energy. So there's this whole vicious cycle of things that could be in this category, right? And so that makes it tough for that to happen. It mimics people's, it makes it hard to diagnose without proper testing overall. So if there's a severe and chronic sleep disorder breathing, physical examination findings might be similar to cor pulmonale or CHF, because that hypoxic pulmonary vasoconstriction. And hopefully you remembered way back in disease class where we talked about how almost every respiratory disease caused hypoxic pulmonary vasoconstriction and therefore elevated all the right-sided heart pressures, right? So it makes a lot of stress on the right side of the heart. It also makes for a lot of stress on the left side of the heart too, especially if they get hypoxic. The heart kind of needs oxygen, just like any other muscle, and even though it's cardiac muscle, it needs oxygen, and it can ultimately lead to arrhythmias and failure as well. And so a lot of it's going to look like CHF or cor pulmonale. If they don't do anything, if the patient is undisturbed, they might quickly doze off during an assessment, which is kind of par for the course if you guys are doing patient care in the hospital. How many times have you been given nebs to patients that are sleep deprived and they sort of doze off in the middle of it, especially if you're talking about, boring respiratory stuff to them, right? How many times have you you've been in class and you've been listening to me and somehow you sort of just doze off and then you woke up and you're like, what equation did he just say, right? Loss of sleep can produce a lot of lethargy on these patients, inability to concentrate and on tasks and questions. Man, I must put a lot of you guys to sleep. It was a little joke there. So these are all signs that you might see with a patient that might have sleep disordered breathing. Although the physical exam might appear normal on the sleep disordered breathing patient, like their heart rate, their respiratory rate, all that other stuff might be looking good. This is when we actually might discover they have it, is when we actually start looking at their sleeping habits. Do you wake yourself up when you sleep? Do you feel well rested in the morning? Do you have a headache in the morning? Right, these are all things. And then that's why it's kind of cool to sort of know what's in the Epworth Sleepiness Scale, right? So, most common problem found in sleep disordered breathing is obstructive sleep apnea. The most common problem found in sleep disordered breathing is obstructive sleep apnea. The most common, hopefully you get my point there. You probably want to remember that. This is defined as the cessation of airflow or the severe reduction, like a 90% reduction or complete reduction of airflow for at least 10 seconds during sleep, caused by something blocking the airway, right? It's an obstruction blocking the airway. So what we're going to see is they're going to have respiratory effort, right? We're going to see that their chest wall or their abdomen is moving, but we're not going to see any airflow on our airflow lead, right? So something's blocking airflow. Usually with this, you'll also see an EEG arousal for at least 3 seconds. Right. So one of the most common findings associated with sleep apnea is snoring. Do you snore or do you wake yourself up snoring? And then usually we'll ask their significant other, do they snore right? Usually they'll be vocal and honest about it. I've never seen someone hold back on their partner snoring or not. This is usually produced during inspiration because remember the soft tissue is vibrating as they're breathing in, so that means they're going to do this as they're breathing in and blocking gas from going into their lungs. It's never a healthy sign. It's not normal to snore. These people also wake up with like dry mouths and sore throats, right? So, and many snorers eventually develop sleep apnea if they don't already have some of it. So that's just something to be aware of. So if you hear a little kid snoring or an adult snoring, that's not normal as far as the material that we're going through is aware of, right? That's not something that should be just noted as a normal daily life thing. It's usually one of the first signs of a sleep disorder in kids and adults. I would pay attention to this too. Snoring is one of the first signs of a sleep disorder in kids and adults. Snoring is one of the first signs of a sleep disorder in kids and adults, right? When we're looking at this, perpetual snoring throughout the whole night is an indicator that and possibly a need for some sort of sleep study. So some symptoms of sleep apnea and sleep disorder breathing. Another common symptom is excessive daytime sleepiness. Right, this means that they have a lot of trouble maintaining, staying awake for the day. So if they're falling asleep with this lecture, for example, right, that's not normal. I'm a very, very polarizing lecture person. Little joke there, but you can see how they can fall asleep sitting at a traffic light. They can fall asleep, just doing daily activity. They can just fall asleep there. That's a sign of excessive daytime sleepiness, right? Unlike sleep apnea, patients with excessive daytime sleepiness are very conscious of the fact that they have trouble remaining awake throughout the day, right? They know that they will fall asleep and take gentle naps here and there. Notice this is bold and underlying. Excessive daytime sleepiness is the hallmark of sleep disorders. I would remember this. This is kind of important. I will ask you that again. Individuals with sleep disorder it's like excessive daytime sleepiness is likely to be a daily experience for them. And it actually might impair with their ability to function. Like it might impair with their ability to function at their job or at school. Right? If they're a kid or an adult that's in school, it might impair their ability to actually interact with other people and impair their employability as well. So it's ultimately a possibility of workplace or school accidents, and may have very bad effects on them altogether in their productivity, whether it's at school or at their job. So tools of the trade, one of the cool things that we can do is we can give them a scale. And so I actually challenge you to Google the Epworth Sleepiness Scale and take it. Make someone that you love take it as well, right? Send it to all the people that you know. Like this should be like the new Facebook thing or whatever. Everybody take this, right? And sort of look, does someone have excessive daytime sleepiness? There's also the Berlin questionnaire. And this looks at risk factors specific to sleep apnea. So the Epworth Sleepiness Scale just looks at excessive daytime sleepiness. That's it. So this is just EDS alone. It doesn't say if you have obstructive sleep apnea or anything like that. The Berlin questionnaire, and I will make note of this, and then you should make note of it. Anything that I make note of is used for sleep apnea. Berlin questionnaire, sleep apnea, excessive daytime sleepiness, Epworth Sleepiness Scale. And then there's the stop bang assessment as well, specific to obstructive sleep apnea. So let's talk about the Epworth Sleepiness Scale to begin with. So this is an 8-item questionnaire that looks at daytime sleepiness, usually just looking for just sleep disorders altogether, not specific to any one. You looks at different situations. 0, they sort of score themselves. Moderate chance of dozing with a 2, and a high chance of dozing with a 3. If they score 1 to 6, then their sleep is appropriate, and there's really no need to further evaluate this. 78, that's considered an average score, and a 9 or more indicates you should probably at least get a nocturnal pulse ox study, right? Get it checked out. Usually this is shown to have a high degree of reliability and consistency with as an evaluation instrument. In other words, doing this questionnaire has a very good sensitivity. It can really tease out pretty easily if someone might be at risk or someone might have it as well. So, like I said, this is something you can look for on the internet and take and send to your friends and family and significant others or whoever, and have them take it just out of curiosity, right? And I think it's a life-saving thing. It's something that can really affect someone's future in a positive way, teasing this out. So this is the version I have, right? Just searching for it, of course. When you're looking at this, like I said, 8 items. So sitting and reading, you would never know sitting and reading. Well, it depends what you're reading. Am I reading a very good, interesting book like Egan's Fundamentals of Respiratory Care? Or am I reading a sort of a slower read like, War and Peace? I don't know. Who knows, right? To each their own. I'm like, who does it at the end of Egan's book? Who does it? Right? Oh, they go home. It's home care. Anyway, so when we're looking at this, this is sort of where they'll score themselves, and you tally it up, right? If you have that higher score, that's a higher chance of excessive daytime sleepiness. They should get it checked out. All right, the Berlin questionnaire. There was a lot of people that went into this one. The Berlin and European Respiratory Care Society, very, very prominent in a lot of this stuff. So they're looking at behaviors consistent with sleep disordered breathing. So this one is specific to sleep disorder breathing. This one is specific to sleep disorder breathing. Okay. Limited risk factors associated with sleep apnea, right? They're looking specifically at sleep apnea. I don't want you guys coming to me after the exam being like, you didn't tell us which one was specific to sleep disordered breathing. This one is divided into 3 categories. One looks at snoring, the other one looks at daytime sleepiness, interesting, and the other one looks at blood pressure and body mass index and factors that all in. So it looks at daytime sleepiness as part of it, and then it factors it together with things that are more associated with sleep disordered breathing. All right, and then that can tell you them if they're at high risk for sleep apnea, and if they are, they have to do so by qualifying in at least 2 of the categories. There's a high degree of sensitivity here of predicting apnea in these individuals. So this is another one that you can use and send to your friends or do with your significant other. If they're consenting, don't just fill it out for them and be like, here, you go check this out. This is my example, the Berlin questionnaire that I have. This is where, there's body mass index calculators online they can use for that one section. And so this is what they're looking at down here. They have to have positive 2 or more responses to questions 2 through 6 or 7 through 9. You guys see this area at the bottom? Right, you can look this up on the internet. It's free, right, to look up overall. And so you can sort of see and give a good sensitivity if someone's at high risk for sleep disordered breathing, right, as far as this goes. And so this is kind of a cool thing. I think it was just a fun exercise when I was in school or when I was teaching this on the campus. I would have the students fill this out, and it was sort of a fun activity. All right, so what do they mean, right? So we could sort of see if it might exacerbate complications in these patients, in our patients altogether. One or both surveys will help provide us with information that might identify where their symptoms are coming from, like their pulmonary hypertension, the corporal venal, the arrhythmias, so on and so forth. So the excessive daytime sleepiness, right? Berlin questionnaire and the stop bang help look at sleep apnea risk factors. So the stop bang was that 3rd one I was talking about before. This was created by Anesthesia. Love those. Love that group. Quickly and effectively identify a person's likelihood of evaluating obstructive sleep apnea. So if I ask you which one's specific to obstructive sleep apnea, which one of the three is specific to obstructive sleep apnea, you would just yell out in your brain, stop bang assessment, right? Questions include symptomatic and physical features, and I'll show you, of course, an example here. But it does look at snoring, high blood pressure, pauses in breathing, daytime sleepiness as well in this one, their body mass index, their age, their neck size, their gender, right? All those things will factor into this. And so its likelihood is based on answering greater than or less than in 3 questions positively. So when we're looking at this, do you snore loudly? Are you tired or sleepy during the day? Has anyone told you stop breathing or you choke and gasp when you sleep? Do you have struggles with high blood pressure, right? Talk about North America, there you go. BMI, right? Is it greater than 35 per meter squared, right? So when you're looking at their age, their neck circumference, a lot of times too, some guys and some ladies may too, or whoever, right, might know their neck size from their dress shirts. A lot of dress shirts out there have a neck size on them, so you might actually already know your neck size. Neckties, I know my neckties all have a size on them, so I actually know my neck size. And obviously here, this is looking at genetic males, of course. That's more likely to happen. So this is one specific to obstructive sleep apnea. All right, the sleep study itself. So the sleep study is looking at multiple different things all at once. The tracings, all those things that we're looking at this screen, looks like the matrix, if you're old reference there, I guess. It's called a montage, and that's what we're looking at there. And the montage has a minimum of 17 tracings. It has a minimum of 17 tracings. Just saying. The tracings will include, but are not limited to, an ECG, right? Looking at the heartbeat, brain waves, EEG waves, eye movement, of course, for when they're in REM, chin movement, leg movement, there's like airflow, abdominal movement, pulse ox, heart rate, body position ones, you name it. But there's got to be at least a minimum of 17 tracings for a montage. Right, and this is the sort of that typical picture that you'll see. So it continuously records data from at least 17 sources, looks at their head, the whole rest of the body, and this whole thing is called a montage, right? You're looking at the sleep categories or the sleep the EEGs up here, then you're looking at the ECG here, and then you're looking at their leg movement, their oxygen status, their body position, all this stuff is in here. And like here was a periodic limb movement, or PLM, right? So different things like that that you can look at here. And here is the thoracic effort, abdominal effort. So you can see if there's respiratory effort going on at the same time that there's airflow when they're looking at the airflow as well. So a lot of really cool, important information here. This is sort of what you'll look like. You'll see all these wires all over these individuals. They'll even do a test for, I think, the narcolepsy one they'll do during the day. I think it's called a multiple latency MLST or something like that, and it's in your chapter. They have these patients that hook up all these electrodes like what you see here, and then they'll walk them around, and when they feel tired, they'll let them go to sleep, and then they're looking at how fast they'll go into REM stage ultimately. So the polysomnography test, when sleep disorder breathing is suspected, a polysomnography test is ordered, and then they go through a sleep specialist. This is where you attach all the electrodes, and there's this like gel that's very specific that sort of helps keep that stuff on there. And they just sort of have to take a shower the next day to get all that gel out of their hair and stuff like that. So it helps keep all that stuff on, all those leads on during the study. The patient should sleep. Now, is it possible that people don't sleep during the sleep study night? Yeah, actually, I've seen that happen. The one time I was there, there was two of them that did not fall asleep at all because it's sort of weird, right? In a weird environment for them to sleep. During this, the patient records. We record the physiologic changes on the patient. Then the next morning, we're going to say congratulations, take all the probes off, and then help them to their car or whatever. And then we're going to score it and then send it to the physician for reporting. We're going to look at the scoring it, which means we're looking at REM and non-REM periods, and then we're going to look for EEG arousals and how many, and their apnea-hypopnea index, all these things, right? Abnormal breathing includes apneas, hypopneas, arousals, oxygen desaturations. All these things are calculated and put into a report. So they're going to put a report together for the sleep physician, right? That will then formally interpret it and then diagnose as necessary. You do not diagnose, right? The physician does, unless you are a physician. That's a whole separate thing, right? If the polysomnography group demonstrates the need for treatment such as positive airway pressure or anything like that, they might contact the company and then have them look at getting you whatever you might need for that. Hopefully the company will fit the person for whatever therapeutic device they need. And instruct them how to use it, provide education. That would be an ideal world. Hopefully these patients also feel comfortable, or the sleep lab has a way to follow up and make sure that these patients don't have any further questions. And that's why I was like talking at the beginning about those CPAP Saturdays and all that stuff. Compliance is going to be one of your biggest things with these patients. It's not comfortable. A lot of them don't feel like they want to clean it and all this other stuff's going on. So it's just important to help improve their quality of life and get them to understand overall you're going to feel better and do better with this, not just physically but mentally. Like you're going to be more productive, you're going to be happier, you're going to be a better participant in day-to-day life with this in your life. And it's not something to hold you down, it's actually a device to help free you up from what's going on, right? And so when you want to do that, when you want to feel better, those are all things that they will discuss with those patients as well. The test itself, we have a lot of criteria we have to meet, and titrating airway pressure to correct them is going to be the big things. During each hour, we have to count the hypopneas and apneas, and that's where we get what's known as the apnea-hypopnea index, or the AHI, and that's apneas and hypopneas per hour of sleep time, right? How many do they have per hour? Not how many do they have overall throughout the whole sleep period, but per hour, what was their apnea-hypopnea index, right? And based upon this, they can look at the severity of their sleep apnea. So less than 5, then usually that's a normal range, right? That's an okay range. If you get up to 15, this is mild sleep apnea. Doesn't really mean you need to do treatment, but maybe lifestyle changes, sleep hygiene changes might be more effective there. If you get closer to 30, that's where you get into the moderate sleep apnea range. And then if you're greater than 30, that's when you're looking at the severe sleep apnea in the adult population. And that usually indicates they might need treatment, like a positive airway pressure or an airway stimulating device like the Inspire or something like that. So infants and children, an AHI greater than 1 is abnormal. So that one's pretty easy, I guess. So when you're looking at end-tidal CO2 greater than 53, end-tidal CO2 normally should be about 5 millimeters of mercury less than PaCO2. So if you're looking at end-tidal 53, that means their PaCO2 might be closer to 60, right? It would be pretty high there. That really means that they're really hypopneic. They're really hypercarbic. And then obviously if they're hypercarbic, their sats are going to go less than 92%. So a lot of times their pulse ox will drop down as well. We can look at their pulmonary function tests, but here's the thing. The pulmonary function test is going to be restrictive and obstruction. Right? Is it going to tell us they have this issue? No. It's just going to show restrictive and obstruction. It's restrictive because they're hypopneic, right? They're not getting good breaths in there, and therefore they have residual atelectasis. And they're obstructive because the airflow, their throat muscles are relaxed or floppy or something like that's going on with their airflow. And so they'll have a mixed or a combined obstruction and restrictive disorder on their PFT. So PFT can support this, but a PFT won't diagnose this. So we can see if it's anatomic or neurologic, if their brain tells them that it's stopping to breathe, or if there's something actually stopping them from breathing, like an obstruction. So we can classify as mild, moderate, severe. An AHI score above 15 generally requires some form of treatment. Right, some form of treatment. Sounds like this one would be one that I would test you on, especially on a final, to know. Disorders can vary from insomnia to jet lag syndrome to sleep apnea and sleepwalking. There's a lot of them out there. A lot of things can go into it. A sleep disorder developing in an individual. It can develop at any age. So it could start at birth, or it could be later on down the road. Here, let me cross one of these out. We will focus on breathing to obstructive, central, and mixed, even though we know there's way more effects out there. Snoring, remember, if you hear snoring or loud snoring, that's airway resistance that you're hearing, right? That's not normal. That's not a good thing. There are 3 types of apnea according to the book. There's obstructive, central, and combined, right? Or that mixed sleep apnea. Apnea is defined as 10 seconds of not breathing. If it's obstructive sleep apnea, it's 10 seconds of not breathing with respiratory effort, right? So the respiratory effort and you don't see any airflow, that's obstructive. If there's no respiratory effort and no airflow, then that's central. Right, central sleep apnea is no breathing and no respiratory effort. Right, so you lost both of them. That's a central issue. So you don't have the drive to breathe with essential sleep apnea. Most likely to occur during a REM sleep. There's something called periodic breathing that happens with babies. We'll get to that in perinatology. Periodic breathings where they'll go apneic for about 10 seconds or more. That's why you'll set your apnea alarm for 10 seconds on a neonate ventilator compared to 20 seconds on like an adult ventilator, right? And so that's a whole separate situation there. Mixed sleep apnea is where you have both of them, right? So usually you'll start off with a central sleep apnea and then it progresses into an obstructive, and then they get that respiratory related arousal, and then they're back to N1, right? So this is where you'll see both of them, and they usually occur together, but it usually starts with central and then goes to obstructive. Hypopneas, like the AHI, apnea hypopnea index. Well, what's hypopnea? How do we know they're hypopneic versus apneic? Well, if the airflow that we're getting is reduced more than 30%, that's considered hypopnea. Now, if it's reduced to 90%, then that's considered an apnea, because that's almost all the airflow has stopped. At 90%, barely got anything going through there, we'll consider that an apnea. So 30%, at least 30% of the baseline flow dropping for at least 10 seconds, remember 10 seconds is that key part there, then that shows that they're hypopneic. Right? Usually with this you will see a 4% reduction in their pulse ox or a 3% decrease. You can also see an EEG arousal for at least 3 seconds with this too, especially with a decrease of airflow of at least 50%. Usually you'll see that EEG arousal come around, especially if it's in that 50% range. So the bullet point from this is the more shallow they're breathing, the more likely they are to have EEG changes and pulse ox changes. I hope you see that there. These can change from this recording even, but as of this recording, the Medicare guidelines require at least a 4% reductions in saturation regardless of arousals, and that's why you'll see the pulse ox studies, very common out there, to sort of get the patients qualified for certain therapies. So obstructive sleep apnea, we'll start with that one. Obstructive sleep apnea, the most common form is in adults. Of sleep disordered breathing in adults is obstructive sleep apnea. So the most common form of sleep disordered breathing in adults is obstructive apnea. Not central, not mixed, but obstructive sleep apnea, right? The etiology is mostly anatomic. So tonsils, adenoids, tongue, their small mandible, a deviated septum, keep going, all these things that can eventually do that. The decrease in tone really decreases the lumen. That's Posey's law. Increasing air resistance may cause, ultimately, when these things get floppy enough, they may cause an airway obstruction. Remember, at least a 90% reduction in airflow, producing hypopnea, which would be at least a 30% reduction in airflow. Continue to make ventilation efforts despite airway obstruction. In other words, you won't see any cessation in their respiratory waveform. So if you're looking at the montage, right, you're looking at the airway montage, you're looking at the montage that has the EEGs, the EMGs, the ECGs, all those things, and you see no change in their respiratory drive, but definite change in their airflow, then you know that's an obstruction, right? So they continue to breathe even though there's that obstruction present. A lot of times if you're actually observing these patients, their chest and their abdomen will move paradoxically. That's that seesaw motion. Hey, guess what? It's actually typed in there. That seesaw motion where they'll move in opposition to each other, so the abdomen will go up, the chest wall will go in, and then the inverse will happen, right, with their breathing. The airflow will be almost inactive or hypopneic, right? And then usually you'll see a drop in their saturation. So pulse ox, usually as it decreases, then you'll see a change in their EEG arousal, because the brain will see that their oxygen levels are low and wake them up. That's usually when they'll sit up or wake up, or they'll just go to early stage of REM, right? They'll go back to N1, N2, just like we were talking about earlier, right? So cessation of airflows with respiratory effort, that's what we're looking at here. So this is an example here. So here we have an example. It's not a full montage, but it's just what we're going to be looking at here. Here is all their respiratory effort. Here's their airflow. Here's their brain waves up here at the top. And then down here is their saturation. So as we see here to here, we see respiratory motion, right? Respiratory motion. Saturations, you notice, didn't drop here either, yet anyway. But the airflow went to low. It was either 90% or 0% of what their baseline was. And so they were trying to breathe still, but there was no gas moving into their lungs. Well, what happened here is their brain woke up, and you see that here with the EEG arousal. So this is a respiratory related arousal, so EEG arousal. So it woke them up, and so what happened? Well, they took a deeper breath, right? You see this, how they took a deeper breath, and then they were able to restore airflow and went back to N1, right? They went back to their N1, they went back to a lighter stage of sleep. And if there was the REM montage, which I wish was in this picture, you would see that they would be back to this EEG N1 stage, which looks the same as REM stage, but you would see the lack of REM, right? So this is what happened here with this obstructive. Now you do see that the saturations drop. The saturations are going to lag usually behind what was going on. Okay, so what do you see going on here, right? So this is actually a hypopnea, right? So we have decreased airflow. You see how we have good normal peaks up here when we're looking at the airflow. So hopefully you're looking at this right now. You see the airflow. You see how the airflow got real shallow there? And then you're going to see the respiratory effort increase, right? Do you not see that these respiratory over here, the respiratory efforts all increased after we had this hypopnea over here, right? So here is the hypopnea, right? Right here is the hypopnea. You see how shallow their airflow was, right? And then their brain's like, oh, well, you're dropping there. You're not doing well there. So I'm going to wake you up and then send you back to like an N1 stage ultimately. So this is just a classic example of a hypopnea. And then that helped wake up the patient to reestablish their airway. So that's where the airway is becoming obstructed, right? They still have respiratory effort here, right? But this is where the hypopnea happened. What does Mount Patty have to do with this? Question we should all ask ourselves. So when we're looking at this is something they can look at to classify the visibility. And I think we talked a little bit about this in critical care techniques on looking at the difficulty of the airway and looking at this. A high score in their Malapati also is associated with obstructive sleep apnea, right? That means that there's a lot more tissue and a lot less visualization in their airway. So A, they would be a more difficult intubation in theory, and B, they're a higher chance of an obstructive apnea as well. Something to think about. All right, so see if you can figure out what's going on here. You know there's an EEG arousal because it actually says that there. But what's going on? What's going on with the airflow? The airflow is staying stable, right? So you have normal abdominal movements. Look at the respiratory effort. Rib cage and abdomen, look at that. Those are pretty constant. But then you notice a change after the arousal. What did the arousal do that changed their respiratory effort? Because you notice they were breathing rapid, and then they were breathing slower after the arousal. What do you think it did? So what was happening is this patient got their airway reestablished. They started to get a little bit hypopnic, right? They got hypopnic. Here's the area. You see how these are shallow and rapid? Like rapid, shallow breathing, rapid, shallow breathing, rapid, shallow breathing. And then their brain woke them up over here and said, you're not maintaining your pH and your PO2s are good, but you're not maintaining good ventilation. So I'm going to wake you up, and that way your breathing will subsequently get deeper and more effective at minute ventilation. We talked about this in pulmonary A&P way back when. But remember, those deep, slow breaths are going to be way more effective at alveolar ventilation and gas exchange than rapid, shallow breathing. So that's what we're seeing here, is the EEG sort of woke them up from that hypopnic breathing, and it changed their respiratory effort. So signs and symptoms, especially here, they fall asleep when driving. That's very dangerous, of course. They'll struggle to stay awake when they're inactive, such as when they're watching TV, or I should add watching social media to this now. Or they're reading, unless they're reading Egan's. I don't know how you could fall asleep reading that thing. That thing's just a thriller all the way through. Not a sponsor, unfortunately. The difficulty paying attention to and concentrating at work, school, or home. Remembering information. I could never remember that. That's always funny. Difficulty controlling emotions. Oh, heavens. Morning headaches for sure on a lot of these individuals, and that's sad. That means it's very physiologic on them. It's been very associated with depression and mood disorders and behavioral issues, especially on kids. What happens if we don't treat it, right? These people are more likely to go into things like diabetes. Like I said, they don't have the energy during the day, so they eat more, they drink more sugary drinks, they drink more alcoholic beverages to help get over certain things. And so they usually have more issues physiologically, like diabetes. They're more prone to psychosocial problems, like I talked about with behavioral issues. More prone to erectile dysfunction or libido issues for sure. Reduced quality of life is a big thing here, right? When you want to feel more energetic and all this other stuff, more likely to have hypertension, chronic hypertension especially, which leads to coronary artery disease. They're more likely to have myocardial infarctions, right? This is if we don't do something or if the patient doesn't comply with the therapy, right? More likely to develop right-sided heart failure and left-sided heart failure, right? More likely to have a stroke. So these are all just bad things that can happen with these individuals. What about kids? What about OSA in kids? The primary symptom of obstructive sleep apnea in kids is snoring. You hear a kid snoring? That's not normal, right? What's a normal apnea-hypopnea index in a kid? Anything at 1 and more is abnormal. So we have snoring in kids not being a good sign at all, right? So sleep apnea can be found in children of any body size. Doesn't have to be a kid that's a bigger kid. It could be a smaller kid. Doesn't matter. Excessive, all those scales that we're talking about early on that were sensitive to sniffing out a sleep disorder, they're not applicable to kids. They haven't done any studies or any things like that as of recording this that I'm aware of. The big thing here that they might see is these kids actually, instead of just being excessively sleepy, they actually might have the inverse. They might actually be hyperactive, which can confuse parents and teachers, and they might think that they have ADHD or something like that. Children can have a lot of social withdrawal that have this, a lot of poor academic performance. They can be more aggressive. Of course, like I said, that irritability, that mental restorative is just not there. Right? Especially, it's going to be a little bit different with kids. Like I said, hyperreactivity, aggressive behavior, social awkwardness, poor attention span, poor academic performance. A lot of these kids will be diagnosed with ADHD, and they may not ever actually look at the possibility of something like a sleep disorder on these kids. One of the things they can do with those kids is a tonsils and adenoid procedure or things like that that might be able to help them to getting a 7-year-old to wear a CPAP machine might be interesting, but that's a whole separate case. As previously mentioned, central sleep apnea is where there's no respiratory effort and no airflow. So we're at least 10 seconds. Remember, 10 seconds is the important part there. So no drive to breathe, right? Your brain just stops telling you to breathe, right? More common in kids, infants, than adults when we're looking at this, especially premature. Preemies, they have central sleep apnea, but we call it apnea prematurity, AOP, right? Fancy name for it over there, and we'll talk about that in perinatology a little bit. The neurologic control of breathing in the brainstem might be injured, so it could be from a trauma, a stroke, a brain lesion. Their brain might be going swelling like encephalitis. Neuroderegulation, radiation treatments for GBMs, things like that. Cervical spine injuries, just heart failure, all those things can lead to more of a central sleep apnea episode. So this is a montage. And this is a central sleep apnea. So here you're looking at the airflow for at least 10 seconds, right? The airflow stops. But what makes it different than the obstructive sleep apnea? Well, there's also no respiratory motion, right? So not only are they not getting gas going into their lungs, but they're also not trying to get gas into their lungs. So that's essential, right? So no thoracic or abdominal movement. And of course, they still get the respiratory arousal, the EEG, respiratory related arousal, EEG, as well as the change in their breathing depth and rate. And then, of course, they still have that lag behind of their saturation, but that's what you're seeing here. Would not be surprised if on a exam in the future, I make you guys evaluate the tracings or the montage to tell me what's going on there. So central sleep apnea is lack of stimulation to breathe. Then we'll have no motion as well as no airflow, right? Snoring, not usually present with this one, right? Because there's no activity to pull gas in. So therefore, they may not snore with central sleep apnea. So that may not be a good predictor for CSA patients. Usually they'll have difficulty swallowing, a change in the ability to use their voice. Body weakness or numbness can be a big part of this. More common in the presence of Shane Stokes respiration. Well, if you remember Shane Stokes, I used to call this one the Bob Ross. They have the apnea and then hypopnea and then normal and then back to apnea and then right. So this is where it looks like those mountain ranges of Bob Ross. So it's apnea on the bookends there. Shallow, deeper, shallow, and then apnea again. And that actually can be a normal breathing pattern during REM sleep here and there too. But if you see it on an adult, it might be also more common with central. Why would it be more common with central? Well, why would Shane Stokes respirations be more common with central? Because the patient has apnea, their body compensates with a moment of hyperventilation and then blows off the CO2, and then there's no drive to breathe, and therefore both respiratory and airflow will cease to let the pH sort of regain itself. So that's why it's more common with Shane Stokes. What about kids? Often found in premature babies less than 37 weeks. Of course, a 27-weeker would also have central sleep apnea. We call it apnea prematurity, but that's something we'll get to later. So premature kids definitely have central apnea. It's called apnea of prematurity. Very common. Also, kids that have congenital heart disorders, as well, their brainstem might be insensitive to or too immature to trigger breathing commands, right? Their brain might be like, hey, I'm supposed to be inside the uterus right now. I'm not supposed to be outside with the air, so they might just go back and not be using their respiratory muscles altogether. All right, and that's why we have to use CPAP on these little babies to stimulate their airway, to tell them physiologically, like their sensors, their baroreceptors in their lungs, hey, you are actually on the outside. You're in the environment. You need to breathe. And so you'll see a lot of these premature babies in the NICU on a CPAP machine or some sort of machine to give airway stimulation, because if without it, their brain would forget to breathe. So they might be on room air. They might not need any FiO2 other than room air. They just need the airway stimulation, because without it, they'll go into AOP. They'll have an apnea, and then they'll go into a bradycardia. Right, so it's a pretty big thing. So one of the things that we can do to stimulate the respiratory drive in these kids is we can give them a device that gives them airway pressure that keeps their brain stimulated to breathe, and then B, we might actually do something like a xanthine, like a caffeine citrate, to help them give them some caffeine, right? To help give them that drive to breathe, that methylxanthine there. Disorders may precipitate CSA in children and infants, including neuromuscular disorders in kids, neurologic, metabolic disorders, GI, hematologic abnormalities, infections that have an accompanying fever, meningitis, things like this all can relate into central sleep apnea in kids. So you got to be careful. What about SID? So I want to take a second here to talk about sudden infant death syndrome. There was a lot of experts, and your book talks about this too, that thought it was associated with central sleep apnea, like kid just forgot to breathe, but there's no evidence to actually show there's a link to that as far as the recording of this. And this is just a sudden infant death under 1 year old. Right, and this is where they have to look at the kid in further detail, right, and review everything all together. The majority of these cases happen when the kid's 6 months of age or less, right? It's most common between their 2 and 4 month old stage. So when we are looking at SIDS in depth and what they have seen, they have a relationship with obstructive apnea, not central. Isn't that crazy? And the big thing here is the body's position, or the position that the baby's in. more than essential sleep apnea event. And so that's where the whole back to sleep program came out, right? Lay these babies on their back, right? And that's the big thing, especially if they vomit or spit up or anything like that. That avoids them from sort of lying in that pool, and that's why their crib, nothing is supposed to be in their crib, right? Absolutely nothing. Even the corners or the sides of the crib, like those crib bumpers and all those things, no, nothing, right? Nothing that can obstruct their mouth and their nose, and that's the big thing. So when we're looking at SIDS, a lot of people used to think it was an essential sleep apnea thing, and in fact it's been more related to obstructive sleep apnea. So I thought that was kind of an interesting thing to put in here. But the big thing here is that sleeping, so back to sleep, if that's all you remember as far as the recording this, it's been the big thing that's helped reduce SIDS cases is that back to sleep program. It's also been linked to bed sharing. That's where the baby sleeps in the bed with the parents. Of course, that's where there's more stuff. There's more blankets, there's more pillows, there's more things that kid can choke on pretty much, or rebreathe into, or vomit into and have it go back into their body, right? More common with maternal substance abuse, as well as cigarette smoking. Wow, cigarettes are just getting a bad rep, aren't they? They're well deserved. Despite a decrease in SIDS in the United States, it still remains one of the leading causes of death in kids less than a year old. So it's not completely gone, but this is why education about this type of stuff is important. And I hope at least that you guys sort of got that from here. All right, what about mixed sleep apnea? I know I got a little off on my on the presentation there. But we went over obstructive sleep apnea, we went over essential sleep apnea. What about mixed? Well, remember I told you that with a mixed sleep apnea, usually you'll start off with an usually you'll start off with a central sleep apnea that will then progress to obstructive sleep apnea, right? And that's usually the normal progression, and we'll show you an example of that here. All right, so you'll see a combination of both. They won't happen simultaneously. They'll start off with the central, and then they'll go to an obstructive. And then without diagnostic tests, it's almost impossible to really confirm that the patient has a mixed condition. Usually, if someone does have it, as far as therapeutics goes, we'll still treat them with positive airway pressure. The CSA component can be addressed by giving them a rate, almost like biphasic positive airway pressure. Read between the lines what I'm saying there. These patients will usually have a rate associated with their CPAP and a separate peak pressure. So biphasic positive airway, biphasic positive airway pressure. I did not use that official word. It's trademarked. The use of pharmaceuticals might help central sleep apnea symptoms, but it's hard to really get that to reverse itself. The nose and mouth and respiratory trainings will differentiate among OSA, CSA, and mixed sleep apnea as well. So let's look at this in further detail. During OSA, the obstructed air results in the cessation of airflow while respiratory efforts continue, right? We already went over that. During CSA, we don't have either. We don't have respiratory effort or airflow. With this one, you have a central sleep apnea that lacks airflow, and then it follows up with a respiratory effort and no airflow. So this might make more sense when we get to the actual montage here. So it's a combination of both of them, but when we treat the OSA traditionally, the CSA still remains the cause of their sleep apnea. So we can treat them with the obstructive, we can give them the CPAP or positive airway pressure, but that might not fix the central part of it. So this is the montage. Hopefully this makes a little bit more sense. This is the mixed sleep apnea. So initially you see the airflow. So hopefully you're all looking at this right now. You see the airflow here is at 0. The respiratory effort is also at 0, right? And so as this patient's here, okay, they stopped breathing. then their body's like, oh, I need to breathe. So there's still no airflow, but there's respiratory effort now. Notice that we kicked in with respiratory effort, right? There's some respiratory effort now going on, but we can't get any airflow in because we're obstructed, right? So we have a central sleep apnea followed by an obstructive sleep apnea. Well, eventually our brain was like, holy moly, right? And it went to an arousal state, which then woke you up to a, maybe an N1, N2, and that caused it. So I would go over what the montage or what the big differences are between obstructive, central, and mixed, and which one comes first in a mixed sleep apnea, right? All right, so these are all summary screens. Yay! I love summer screams. Diagnostically, sleep apnea is defined as a cessation of airflow for at least 10 seconds during sleep, caused by an obstruction of the airway. We're talking about obstructive sleep apnea. During patients that might be unaware they have sleep apnea, it's likely they've been told they snore. Snoring is a big thing here. It's a noise produced during inhalation, most likely caused by something oropharyngeal, most commonly. Excessive daytime sleepiness. Patients with sleep apnea may be conscious of the effects of daytime sleepiness on their lifestyle, so that's one of the things that we want to look for. The Epworth Sleepiness Scale, that's the ESS here, is a questionnaire that we can use. So is the Berlin questionnaire as well as the Stop Bang assessment to look for different things. Remember, the Epworth Sleepiness Scale looks at daytime sleepiness. The Berlin questionnaire focuses on sleep apnea. And then the Stop Bang is specific to obstructive sleep apnea. Right, Stop Bang is a quick way to look for a person like that having obstructive sleep apnea. So where I have personally seen the Stop Bang used the most is anesthesia pre-surgery. If they're going to put someone under general, they want to know how likely they are to obstruct, and that's going to be especially when they go to extubate that patient in PACU, or in the OR or in PACU. They want to look at their extubating to CPAP versus just regular extubating to like a nasal cannula. Two major states of sleep. There's non-REM and REM. There should be 3 stages of non-REM. They get progressively deeper. You cycle back and forth between the non-REM and REM every 60 to 90 minutes. You should have about 4 to 5 cycles during an 8-hour sleeping period. Good luck with that one. Sleep begins at stage 1, progresses 2 to 3. As you get older, you get less 3. Boo. During non-REM, the brain is in a state of rest while the body can still move and respond to stimuli. And during REM sleep, the brain becomes more active and the body experiences muscle paralysis, therefore physiological rest a little bit there. And changes in ventilation, blood pressure, all that stuff can change when you hit REM. Obstructive sleep apnea, usually you'll have almost no airflow, so 90% or greater airflow reduction, while the patient's still trying to breathe. Central sleep apnea, you're not going to have any effort to breathe or any airflow. Mixed starts with a central and then goes to an obstructive, right? So a typical montage has 17 tracings or channels to look at: EEG, ECG, eye movement, of course, for REM and non-REM, chin movement, leg movement for PLM, snoring, body position, abdominal movement, pulse ox, heart rate, all that good stuff. Apnea ooh, this is good to look at. The index less than 5 is considered normal, and AHI less than 5 is normal. Mild is between 5 and 20. Moderate between 20 and 40, and greater than 40 is severe in adults. And this is just one way that your book breaks this down. This is all from your, I believe, Wilkins book. And then remember, your disease book also goes over this as well. We covered sleep disorders in disease class a little bit as well. So that's also a good secondary resource, is your cardiopulmonary disease book. This is just sort of breaking down the amount of time you spend in each stage. All right, so what is going on here? I will not answer this, right? This is something for you to go through. Do you see apnea? Right? Do you see loss of airflow? Do you still see respiratory motion? Do you not see respiratory motion? Do you see both loss and respiratory motion during the apnea? What is this? Mixed sleep apnea, obstructive sleep apnea, central sleep apnea. What is this? What's this? Central sleep apnea, mixed sleep apnea, obstructive sleep apnea, no apnea, hypopnea. Ooh, what is this called? What is this called? It looks at all the different stages in REM and it breaks it down. It's a graph, there's a quick hint, of each phase of the sleep.